Again, thank you all for the invitation and the learning. My engineering partner, Dr. Barbour, is going to jump in for a little bit of this presentation. I am also an ENT surgeon. Well, the presentation's loading just a couple of contrasting points. So very similar to France, the ENT surgeons do all the flexible laryngoscopy. We do hundreds and hundreds a year. We try to make our team as available as possible to the OAP team. We do this in the unit with a portable cart in a non-sedated child. We don't worry as much about the NPO status. If there's feeds, we'll just stop them. But we don't make the babies necessarily NPO in anticipation of a flexible scope. And then just to touch on the previous point, recording these is critical. There's lots of movement, there's lots of secretions, and the ability to go back and review the videos and slow them down is so helpful, not just in assessing the patient's, the current patient and the physician, but also learning about what you can do better moving forward. And so that's really important. Just a little bit of background for the non-otolaryngologists here. So awake fiber optic laryngoscopy, just to even diagnose Robin sequence, has really moderate to fair intra and inter-rater reliability. This is not, from my previous presentation, a very quantitative and sometimes even reliable exam. It changes with the baby, it changes with the person who's doing it.
We only have 5 minutes, so we all know that. Sorry.
I'm not sure that everybody does that.
In this audience, I'm sure.
I respectfully disagree. And when we look at the literature on this, it's harder for non-otolaryngologists to interpret these exams. So the challenge is small baby, the larynx is high, usually around C2. It moves a lot. There's secretions, and the duration of the scope can really impact the baby. As I said, we record the scopes. We prefer to use a distal chip scope compared to a flexible fiber optic scope because the image quality is higher. The view is restricted, and there's no validated grading scales. Mike?
Yeah, so it's quick. So Jake asked me to give a quick overview of this new approach that we have at Seattle Children's to design the spur trajectory. This is implemented since January. We've done 6 patients on it, so take everything with the acknowledgement that it's constantly evolving and we're learning a lot. So we came into it knowing that we had kind of a unique data set because we had a CT image of these patients, and we also have the 3D model of the dental impression and the appliance. We use a handmade appliance. The other factor is that we're using the thermoplastic spur. And when I went to go watch the Barbara Marlena bend the spur, it looked incredibly challenging just to make a repeatable bend with their hands in the boiling water. And so we thought, okay, my engineer brain was like, how can we make this easier? Can we make a guide to bend the spur to a specific trajectory? And that's what we try and do. And so our process now is we take the impression and the dental appliance, the OAP appliance, and we align it to the CT. The impression is really important because we can get a really good alignment with the cleft. And then we align with all 3 planes from the CT scan. And that then positions the appliance in the patient, and we can use that to help identify the trajectory of the spur. So our current kind of planning guidelines, we first target the vallecula as kind of the target for the tip, not where the tip actually ends, but the kind of trajectory. We try and match the slope of the posterior oropharyngeal wall. And then we'd like to have like a larger radius of curvature rather as opposed to a smaller radius of curvature to have a more even distribution of the force on the tongue. So avoiding sharp bends, basically. We then we basically displace the ideal curve, which is shown in A, 2 millimeters posteriorly. And these are kind of 2 target trajectory spurs that we use to try. And so I'm showing here a pre-bent and a straight OAP that we then modify to these A and B trajectories. We do that using these bending guides. So we digitally manufacture the specific shape that we want the spur to look like. The thermoplastic then really nicely molds to this printed part, which allows us to kind of confidently say, like, okay, this is where, or the shape of this spur is what we think we want based on the CT. And we provide 2 options for trying that the team thinks is helping them confidently feel like they're starting off at least on the right foot. Yeah.
So I'm just going to skip the videos for time's sake, since we've already looked at some really good videos. I'm happy to go over them later. But what we can do with Mike's technique is compare the delivered appliance, which you can see here in yellowish, versus the draft. And so this is a way of at least quality checking and understanding what, and comparing our scope video to the CT to how the patient's doing. I don't know that this is, 100% necessary, but it gives us a safety and a quality check just because of the subjectivity, to my previous point, of the flexible laryngoscopy. And then again, I'm going to skip the videos for time's sake, but again, the same thing, the draft device versus the delivered device. And you can see there's some pretty significant differences. And again, this is a learning tool. We can see what we were thinking, we know what we were thinking, and then what we evolved to, and we can compare that with the changes that were made, both in the dental lab and on the flexible scope. So we'll stop there.
I would like to see the videos actually.
Yeah,
Because I think that you can see then why it's not the direct position, maybe.
We can, I'm happy to go through them for the sake of time. But we have them, we're happy to go over at lunch break or whatever.
Okay, thank you. Thank you very much. Let's discuss these three talks now together, and then we move on to the next conversation. So the speakers can come up to the front, and you can pose your questions now.
we had a question in the chat.
Oh, questions in the chat first, perhaps. Yeah, that's a good. Do you have any suggestion for achieving clear imaging with endoscopy if the baby has a lot of secretions? Suctioning can help.
Yeah, sometimes it's useful to have a little bit of glucose with you. So we use glucose just to make the baby calmer, and they are swallowing. So, and sometimes if they are swallowing, and the secretion is going out without sucking because they don't like the sucking as well. So sometimes we use this glucose, so or exposure or whatever, and it helps a lot. So maybe you can use it.
We'll do an oral suctioning. Yeah. And sometimes an NP suctioning, depending on how secretion-y the baby is.
How often are you seeing aspiration on the scope of secretions when you're doing this?
It's not something that we're really focused on during the exam, but you do see it. Yeah, I mean, the baby is very stimulated. You're holding the airway open. The secretions are going in and out. The larynx is moving up and down. Again, it's at C1, C2 in a baby. In an adult, it's around C5, C6. So you're talking about a small space. So the secretions only have certain ways to go, and they're going to take the path of least resistance. And if the cords are open, where they're going.
Have you ever considered, because I saw the spur is like centrally placed, and that could pull on the epiglottis, but have you considered making like a split spur or something like that, where it diverges laterally, and where you could possibly avoid that? I'm not even sure if it would avoid that, but is that
High run still here?
anyone ever?
Because high run has this kind of split spur. Interpret.
But it's more for the width of the.
Yes,
It's for the plate part, the base of the plate, not the spur. We've never done that before.
Yes,
So we have
I
to
think
make
it's difficult if you want the wire.
Yeah, so you need two wires. in the
Yeah,
spur, so-
I mean,
I think it's I'm not sure it's a good option because the problem is mainly on the median part of the tongue.
Yeah.
And the second point is it's not a large spur. So if you have two split spurs, we have talked before about the risk of breaking. You tell us that in Tübingen you don't have. We have the experience of one spur broken in the child, and even if it's not large, we have during the prototype trying a spur broken. And I think that if you have two spurs, even if you have a wire, it would be more risky, and you increase the risk of spur broken.
Yeah, naturally, but I'm talking about it conceptually, right? Where you can use different materials to make it harder as well. But I'm talking about it conceptually. Do you think that it would make a difference if you could pull it forward?
As you said, it's in the middle of the spur. That's the problem. Most of the problem around.
I think the fact that the spur puts some slight pressure on the hyoepiglottic ligament and kind of impacts some of the laryngeal translation as well as the movement, actually helps with the airway improvement. So I actually think the midline spur anatomically makes more sense to me as an airway surgeon than that bifid.
Do you have a question?
Yeah, I have a question. You said when there was a cleft palate, you used the nasal flow, but also to alter the TPP with a ring or tube. That's what you mean with that?
So if we added, have such a spur or whatever, or tube or flute, yeah, you can do that. And we have had done that before, but it's very tricky to do that. Even if you have a circular obstruction, and I showed you this bronchoscopy, sometimes it's not enough to have only the spur. Sometimes it's necessary to have an individualized nasopharyngeal tube. It's something like that. So if it's working, yes, but it's very tricky to do that. And we have had a bronchoscopy. It works extremely well when the patient has the plate in place. But if you remove the plate, it was very tricky. And the reason we sent them home with a tracheostomy was it was working with the plate extremely good, but the changing of the plate was so severe that the parents can handle that at home.
Yeah, okay, thanks.
It's an interesting point, like, as the ENT surgeon, to remember that okay, we are all trying to reduce our rate of tracheostomy, but sometimes we have to remember that tracheostomy is a good option, safe in experienced team, only for a few months. So instead of staying at hospital with a lot of different devices, trying and spending a lot of months waiting for spontaneously cure, you perform a tracheostomy, the child go at home, and in a few months you can.
I just like to I love that comment. I'd like to contrast our experience in the US with that. At first, we will perform a diagnostic laryngoscopy before trying to rule out any other airway lesions, like the molecular cyst example that was provided, vocal fold immobility, all kinds of other things that can happen there. So we, again, view that as part of our initial assessment, our otolaryngology physical exam. But a tracheostomy in our system means the patient's going to be in the hospital for 6 to 12 months, sometimes longer. I'm trying to be global in the US. Seattle's on the longer end of that. In order to arrange home care and train families, there's just a lot that goes into it. So we could easily, I agree with you, it's a safe, easy procedure, but that would keep our patients in the hospital indefinitely in some cases.
In France, after 1 month, we can go at home.
Not in the US.
That's it's a very interesting debate.
But it's a problem in Germany as well. So we haven't had so much outpatient home care for them. So it's really a problem for patients.
Yes, we actually, probably very similar to Germany, we work not to do a trach if we can.
A detailed question. You talk about the length, about the angulation, but not about the width. And I was surprised listening to Hiram's presentation yesterday to see that the shape of her TPP were quite very much wider than ours.
So the width's not necessary, as he already said. It's just you're really interested in the middle part. You don't really need to gather all the tone per se. And two, Hiram, she's not using any safety wire. And even if you will be using a safety wire, the wider you have it, the more likelihood you have of the pieces in the sides breaking.
Okay.
So that's why
and the
you also have
second
this
question is for new teams who wants to go on the process. Finally, the CT scan. It's useful, interesting research. Does it help you really?
So we get the CT scan for clinical indications. The patients are being worked up for an escalation of care and considered for mandibular distraction versus tracheostomy. We don't do TLA in most centers in the US. So since we have it, we do feel that it adds benefit, and it also helps us learn. It's another modality that shows us the anatomy, and it allows us to see, especially in that sagittal plane, kind of how we could improve our approach. If we were not getting CT scans for the escalation of care, we would not CT these patients.
And Veronique, just to add to that, I think one day we hope to be like Connie described, you see the baby, I get a sense of what the length needs to be, but we're definitely not there. And so having that imaging and a team of really brilliant folks looking together, reviewing, looking back, we hope to be able to share that and find a way to talk and share that and that how imaging has helped us. But ultimately, I think we're still learning from each patient.
And the other thing is most centers don't have an engineer like Mike who can help create the images and the overlays and all the technical aspects that are helpful from that approach.